Hello guys, welcome to Breathe Medicine. In this video, we're going to discuss about Cushing syndrome. Before we get into the topic, we'll have a look at the mnemonic with respect to the features of Cushing syndrome. So Cushing, C stands for central obesity, comedones, and collagen fiber weakness. U stands for urinary free cortisol and glucose intolerance. S stands for striae and suppressed immunity. H stands for hypercortisolism, hypertension, hyperglycemia, and hypercholesteremia. I stands for iatrogenic, which is the most common cause due to increased administration of corticosteroids. And N stands for non-iatrogenic causes, which is mostly neoplasm. And finally, G stands for glucose intolerance and growth restriction. So what is exactly Cushing syndrome? There is excessive activation of glucocorticoid receptors, which will lead to hypersecretion of the glucocorticoids. As we saw in the mnemonic, the most common cause being iatrogenic, which is due to increased administration of corticosteroids, etiology is classified into exogenous causes and endogenous causes. Endogenous causes are further classified into ACTH dependent and ACTH independent. ACTH dependent are pituitary adenoma secreting ACTH and ectopic ACTH syndrome. The tumors associated with ectopic ACTH syndrome are bronchial carcinoid, small cell carcinoma, and other neuroendocrine tumors. ACTH independent includes three causes, which are adrenocortical adenoma and adrenocortical carcinoma, and rare causes like ACTH independent macronodular hyperplasia, primary pigmented nodular adrenal disease, and McEwen-Albrecht syndrome. So how does the patient present to you? As soon as the patient walks into your clinic, just with observation, you can easily identify the patient as a suspect of Cushing syndrome. We'll see the clinical features from head to toe, so it will be easier for us to remember. If you observe the patient's hair, it will be thin and sparse. Patient may show features of psychosis or depression if the brain is involved, and you can easily identify the cataract and mild exophthalmos. Due to involvement of sex steroid action, there will be acne, which is also known as comedones. Then there's facial plethora, a red complexion, which is one of the earliest signs of Cushing syndrome. Moon phase is a classical feature. When there's cardiovascular involvement, the patient will present with hypertension, hypokalemia, and edema. In GIT, peptic ulcer will be seen, and there's decreased skin thickness in the patient. Central obesity due to distribution of fat by lipolysis, and when you do a blood checkup, hyperglycemia, a metabolic condition, is seen due to glucose intolerance. With respect to bone involvement, the patient may have exuberant callus formation with fractures and osteoporosis. Patient is prone for easy bruising due to defective platelet adhesion, and they have a high tendency to get infection. Wasting and weakness of proximal thigh muscles, that is proximal myopathy due to protein muscle breakdown. And finally, there's purple striae, mostly seen in the abdomen due to collagen breakdown. In women, due to sex steroid action, the patient might present with menstrual disturbances such as amenorrhea. Now, if you look for the pathological aspect, increased glucocorticoid will aggravate three metabolisms, that is carbohydrate, fat, and protein metabolism. When there's increased carbohydrate metabolism, there's increased gluconeogenesis, which will lead to adrenal diabetes. When there's increased fat metabolism, it will lead to redistribution of the fat and thus causing central obesity and buffalo hump. Increased protein metabolism will activate both catabolic and anabolic action. Catabolic action includes muscle protein breakdown, which will cause proximal myopathy. Then there is bone involvement, which leads to osteoporosis and short stature, collagen breakdown causing purple striae, defective platelet adhesion causing easy bruising or ecchymosis, and facial plethora due to sex steroid action. Sex steroids also cause acne, hirsutism, and amenorrhea. So now we will see with respect to mineralocorticoid action. Increased cortisol will activate epithelial sodium channels, which will cause salt and water retention, thus leading to hypokalemia and alkalosis. Increased peripheral resistance will lead to hypertension. When it crosses blood-brain barrier, the patient will present with psychosis or depression. The two main mechanisms involved in causing diabetes in Cushing syndrome are insulin resistance, which will automatically decrease the glycolysis, thus increasing the sugar level, and the other is increased cortisol, which will increase gluconeogenesis and increase the sugar level. Now, to summarize the clinical features of Cushing syndrome from head to toe, there's hair thinning, psychosis or depression, cataract, mild exophthalmos, acne, facial plethora, moon face, hypertension, peptic ulcer, decreased skin thickness, hyperglycemia, central obesity, striae, may have exuberant callus with fractures, osteoporosis, wasting and weakness of proximal muscles like thigh muscles, bruising, and in women there's menstrual abnormality, and there's also buffalo hump. Investigations and management of Cushing syndrome will be dealt in the upcoming videos. Thanks for watching, guys. Do like, share and subscribe for more videos.